Carolyn, who's just to this side of her, recently completed her master's degree in engineering design for healthcare at the University of Cambridge. Her research is entitled Applying Inclusive Design Principles in the Assessment of Patient Experience. It's investigating barriers that UK patients face when physically assessing NHS services, and involves applying population data using inclusivity tools to highlight the problem areas along the patient journey. So over to Carolyn.
Hi there. My name is Carolyn Banouk. I'm most recently the graduate student from the University of Cambridge, and I was working in the Engineering Design Center. I have to admit, my background is from Queen's University, mechanical engineering, so don't hate me yet. But anyways, I'm just going to talk to you today a little bit about my experience in the UK working with the NHS and some of the projects that the University of Cambridge is getting involved with in the healthcare stream. So first and foremost, a little bit about the Engineering Design Center and what it is. It's one of many engineering departments at the University of Cambridge, but I like to call it the most eclectic. There are 7 research groups, and they range everything from aerospace, nuclear, to healthcare design and inclusive design. So these are the 2 I'm going to talk to you about a little bit today, because they're the 2 that I was participating in. So first and foremost, healthcare design. Recent projects have involved looking at hazard analysis, designing medical devices, assistive technologies, as well as patient safety. And what you can see here is actually patient safety software has been implemented in the hospital setting. Our inclusive design team is actually much larger and has in the past been more popular because it's more on the product development side. So they look at design practice for products, simulating user capabilities. What you see here is a design for simulating different stages of arthritis, as well as they've developed some exclusion audit tools. And the reason I fall between these 2 is I've actually used the exclusion audit tools, which applies population data collected in the EDC with the government back in 1997. Now you may say 1997, that's quite dated data, however, it's the best that the government has allowed for at this time. So anyway, so I applied the exclusion audit tools in a healthcare setting. So I'm just going to give you a little taste of my master's project. So I was fortunate enough to work in Addenbrook Hosptial, which is one of the top leading teaching hospitals in Cambridge, top in the UK. To give you a taste of the size, it's got about 1,200 beds, so it's about the size of Sunnybrook Hospital. And as you can see, it's got about a $610 million Canadian annual budget, so it's a very large hospital. So I was fortunate enough to work in 4 different departments, so two clinical departments and 2 administration departments. So this gave me quite a top-level view of the healthcare system in general. So in speaking with all of these departments, as you can imagine, they all have varying views of what they desire and what they want the EDC to become a part of. But I came up with a short list of what they hope to improve is obviously the efficiency, accessibility of their services, and ultimately improve patient experience. And they hope to reduce missed appointments. In 2009 alone, it cost the government £575 million alone for missed appointments. This is a big issue, as well as reduce patient complaints. So these are the things that I combined to form my research question, which is what barriers do patients experience in accessing NHS services, and to what extent do their capabilities affect how they negotiate these barriers? So the 3 most important things here, I look at patient experience, accessibility, and how the UK population's capabilities affect this accessibility. So first and foremost, what is patient experience? A lot of people like to interchange words such as patient experience, satisfaction, expectations, patient values. So a lot of my initial research was looking at how do we define patient experience and how do we appropriately measure it. Second, looking at how do we look at accessibility. In my project, and what I'll talk a little bit more about, is doing a patient journey task breakdown. So I guess you could say this is where the industrial engineering comes into it. It's really a system breakdown. And capabilities. Well, as I mentioned, the EDC luckily gathered all this data in 1997, so I was able to do more of the statistical analysis side and quantify the size of certain problems by applying population statistics. So I don't want you to read all this because it is a very top-level project here, but I want to give you a taste that I did a few projects within Addenbrook Hospital alone, but also some external studies which were more on a national level. So for example, a public opinion survey I conducted through nationwide charitable organizations, but also the patient journey study, which was the task breakdown and allowed me to quantify problem areas, which was most useful to the hospital in the end. So for example, we think of the patient journey as starting in their home and ending in their home, but I wanted to look at accessibility. So what I called that is the preparation stage. So booking the appointments, preparation, transportation, and wayfinding. So this is how I looked at accessibility. Now this is an extremely oversimplified version of one subtask. So for example, booking the appointment. One way we can do that, using a telephone. So I've shown here that using the telephone can be broken down into steps. You have to make the call, request the appointment, agree on details, and so on. However, what's important to know is the difficulty level of each of these steps. So making a phone call may sound easy to you and me, but to the less able population, they must be able to physically pick up the phone, have the dexterity to dial the phone, the cognitive ability to remember the task at hand, and so on. So it's actually quite in-depth approach. And using the calculator that I described, using the population statistics, we were able to come up with the percentage of the population excluded from each of these tasks. So for example, 9.4% of the UK population excluded from making a telephone call. It's quite a large number. But you might be saying, well, some who are excluded from making a phone call are also going to be excluded from agreeing on details. So one of the biggest statistical nightmares, I'll call it, is to deal with co-occurrence of issues across the tasks. So I'm not going to go into too much detail, but I did do a Venn circle analysis. It was a 15-segment statistical analysis in order to come up with results such as this. So for example, booking an appointment by the telephone excludes 9.7% of the UK population. And it's numbers like this that the hospital really likes to use, both for PR reasons and eye-opening experiences. So overall, combining the network of the whole preparation stage of the patient journey, I found that 12% of the UK population is excluded from accessing NHS services. And by accessing, I mean on their own. So without assistive technologies, without the use of a carer or friend or relative helping them out. And this chart here shows who is most excluded. And it turns out those with reach, stretch, and dexterity problems are the ones who are most affected here. Whereas often we see people accommodating for those who are visually impaired. It's little things such as revolving doors and sliding doors. And I'm not going to talk about doors because that's a huge issue in itself. But anyways, those with reach, stretch, and dexterity problems. So I've given you one taste of one of many little projects I came to talk about today. But the first thing my first insight is that accessibility is key. Once we found 12% of the population is unable to access services, I thought if we were able to solve this problem or even reduce this number by improving those reach, stretch, and dexterity patients, we can not only, reduce those missed appointments, we can improve accessibility of services as well as ultimately improve the patient experience. So I think that accessibility is definitely key here. Technology implementation may meet the needs of the less able population. I know we all know this, and I know there's many technologies out there that have been developed for certain members of the population. However, the important point here is implementation, and the biggest barrier to that is system complexity. Now, I have to admit my experiences in the NHS, which is very much a business, but it was definitely interesting just working with 4 different departments who didn't know what each other were doing, and something as simple as how they distributed mail to their patients differed astronomically within the same hospital. So obviously, I guess I would say one of my insights is if we can focus on trying to improve communication and reduce system complexity, that it might be the way to start in Addenbrook Hospital anyway, particularly. So that's it. So I didn't talk too much about my project. Will be available online in July. But if you have any questions, that's my alumni email. You feel free to send me an email with any questions. And that's it.